name is Abida Hijaz. I am Professor Orthodontics. I did my Bachelor of Dental Surgery in year 1972 from the D. Montmorency College of Dentistry, Lahore, which is a parent school of dentistry in Pakistan. Then I joined the same institute in year 1974 as dental teacher. And I did about 14 years of teaching there in the D. Mont. For my postgraduate qualifications, I did my postgraduate diploma in orthodontics from the Punjab University, followed by MCPS in orthodontics from the College of Physicians and Surgeons, Pakistan. Later on, for my master's in orthodontics, I went to Marmara University, Istanbul, where I got my master's in year 99. Back from Turkey, I joined Children's Hospital at the Institute of Child Health in year 99, which is now upgraded as the University of Child Health Sciences. Children's Hospital is a tertiary care hospital providing all services under one roof. At that time, the Children's Hospital was recently constructed and was equipped with state-of-the-art equipment. There I was given opportunity of establishing a cleft clinic in year 2000. In the following years, we found the greatest opportunity of treating cleft patients from all over the province and beyond, right from birth through adolescence till adulthood. During that period, we conducted a number of research studies regarding cleft deformities along with my fellow trainees, and the ring plate is one out of those projects.
Intervention of the ring plate. The initial implementation of the alveolar molding ring plate occurred in 2001, followed by the publication of a relevant article in December 2003. Regarding the ring plate design, credit is due to my then plastic surgeon colleague, Dr. Saeed Ashraf Jima, who played an integral role in conceptualization of such a device. At that time, I was working at the Children's Hospital and the Institute of Child Health, Lahore, a recently constructed tertiary care hospital providing all services under one roof. Saeed Ashraf Jima suggested to design such a device for complete bilateral cleft infants that could move the premaxilla back and make the surgeon's life easy. Prompted by his incentive, I undertook the design of such an appliance that took a few months to complete till its fabrication as self-retentive molding ring plate. Successful results were attained along with some coliomalar and prolabium length increase, whereas nasal molding was not at rest. The ring plate was then modified with wire nasal stents in 2011 for nasoalveolar molding and was published in 2013. This slide shows extraoral front and side view and intraoral view of a baby born with complete bilateral cleft of the lip and palate. The protruded premaxillary segment suspends from the tip of the nasal septum. The nasal septum is hyperplastic, coliomela severely deficient or absent, and lower lateral alar cartilages are flared and stretching over the cleft. The greatest challenge for aesthetic reconstruction is anteriorly displaced premaxilla. This slide shows a cleft proforma. Consent was taken from the parents and a detailed proforma was filled that ruled out intermarriage, family history of clefts, or any other related drug intake. The baby was the first child of his parents. This slide shows treatment initiation with different steps of lab procedures. Orthopedic plate with anterior acrylic ring was fabricated for this infant born with complete bilateral cleft of the lip and palate deformity. Impression trays are custom made from self-cure acrylic to record impression of the cleft infants. Initial impression of this baby was recorded with the infant custom tray at the chair side with rubber-based heavy body putty impression material. The baby is kept in caregiver's lap in forward posture, keeping head in bending down position. This precaution is taken to avoid inhalation of saliva as well as flowing of impression material back in the throat. Care must be taken to keep the mouth wide open with operator's fingers to keep the airway patent. The impression is then poured in stone plaster and working cast is prepared. The defect part is boxed in modeling wax and orthopedic plate is fabricated from self-cure ortho-acrylic using pressure pot. This plate is then finished and placed over the cast for ring fabrication. The acrylic ring surrounds the premaxillary segment till its junction with the anterior margin of the palatal plate at both ends. The ring plate is then finished and polished and is ready for insertion. The upper surface of the palatal plate of the ring appliance shows its distinctive feature. This is soft acrylic that fills the defect part, providing retention to the appliance. The top surface of this plate is made rough in the area where soft acrylic will be placed. After addition of soft acrylic, the appliance is inserted in forward posture of the baby, maintaining airway. Remove the appliance after 2 to 3 minutes and make sure that the soft acrylic does not interfere with the nasal air passage. The last picture shows appliance on insertion. Baby is wearing the plate which is retained in its place without the support of extraoral means like head cap elastic tapes or extraoral elastics. Parents are shown how to insert and remove the appliance which is worn all the time except for routine cleaning. They are instructed to wash the appliance thoroughly after every feed. Parents are educated regarding posture of the baby while feeding, diaper changing and during sleep. Parents are also shown how to administer 3 antifungal drops on the upper surface of the palatal plate, 1 drop in the middle and 1 on each lateral side of the plate at least 3 times in a day.